Welcome to the Jerry Powell Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, I see a couple more people in this room, more than usual that we have. Would you like to start off with some introductions?
Yes, so on stage with us, we are honored to have Rachelle Bernacki and Joe Paladino, who are from Ariadne Labs, Harvard, Dana-Farber Cancer Institute. They're both physician researchers. Welcome to the Jerry Powell Podcast.
We're delighted to be here.
We're so excited to be here. Thank you.
So we start all of our podcasts the very same way. Do you have a song request for Alex to sing?
I do. How Sweet It Is to Be Loved by You by James Taylor.
Great.
And Alex, there are a couple other people in this audience. Are you going to get them involved?
Yes, so we could really use your help on the chorus. Everybody knows this song, right?
I think so.
All right. To be loved by you, yeah. How sweet it is to be loved by you. It's great. I needed shelter of someone's arms, and there you were. I needed someone to understand my ups and downs, and there you were, with sweet love and devotion, deeply touching my emotion. I wanna stop and thank you, baby. I just wanna stop and thank you, baby. How sweet it is to be loved by you. Yeah! How sweet it is to be loved by you. One more time, sing it out. Sweet it is to be loved by you. Yeah, nice.
Woohoo! Very nice.
So, why did you pick that song?
So, as you know, my dad died this past October, and this was a song I danced with him to my wedding, and I think it just so embodies the way I feel about my dad. But I also think that there's a metaphor with palliative care, and you needed someone to follow our ups and downs, and there you were. And I think that palliative care does that, and I think that everyone in this room does really hard work, and so I love the stop and thank you. So everyone should just sort of thank themselves, I think, for doing the work that we do, because it is really hard, and I think it's important. So
that's beautiful.
Yeah.
Thank you for sharing that story.
Yeah.
So at 1:30 today, so more than 8 minutes ago, 2 papers just got published. This is a JAMA Oncology paper evaluating intervention to improve communication between oncology clinicians and patients with a life-limiting illness, and also a JAMA Internal Medicine paper, Effective Serious Illness Care Program in Outpatient Oncology, done by your group. And we were hoping just to chat about kind of serious illness communication, the project that you're doing, kind of these 2 articles. But before we do that, maybe you guys can talk about how did you get interested in talking about serious illness communication?
Sure, I can start. So I think there's a sense when you're doing clinical palliative care that the need is endless and that there's more demand than we can ever possibly fulfill. And I definitely felt that. And so the opportunity to sort of go to colleagues and start moving this work upstream and outside of palliative care was just really appealing. And so I was excited about it.
Joe?
Yeah, for me, I trained in primary care and population medicine before I did my palliative care fellowship. And we thought a lot about how to improve care and outcomes for broad populations of patients. But one of the questions that we wrestled with constantly was, how does that translate to the person right in front of you? And so when I was, fast forward, when I was a clinical and then a research fellow in palliative care, Rachelle and my mentor, Susan Block, as well, described the serious illness care program, and they gave me our foundational tool, the conversation guide. And for me, it really represented that bridge, like between the population and the personal, because it had these really deeply intimate human questions that many of us know in palliative care get to the heart about what matters most to patients. But the idea as Rachelle said, was to make this accessible to broader populations of clinicians and patients. And that was just really exciting and compelling to me, and so I've been with the program ever since.
So maybe we can start talking about, just sort of jump into the trials, the trial itself, and talk about what it was you were testing.
Yeah.
So what is this? Is this a checklist?
Yeah. So interestingly,
No,
yes.
it is not a checklist.
We started with the idea. I actually interviewed with Atul Gawande for the palliative care checklist job, and with sort of like a very skeptical mind. And but then when we started talking about this idea that we would have a guide or a framework to help clinicians talk about really difficult things and gives people some idea of where they're going, that was much more appealing. So the intervention itself consists of tools, which the main one is the Serious Illness Conversation Guide, training, and system changes. And the training is a 2.5-hour training. It was specifically designed to fit into a busy clinician workday, like that we could actually get oncologists to come to the training. And then the system change is where Joe and I spent 90% of our time.
Could you say a little bit more about what that training entails? A little bit of a flavor of the guide. Like, are there one or two like key questions that you try and make sure are included in that every clinician gets to?
Yeah, so I think the idea behind the Serious Illness Conversation Guide is that it has gentle, softer language with hypothetical, open-ended questions. So it's meant to have...
Like, do you like puppies and kitties? Or?
No, it asks, for example, it's meant to have earlier conversations. So, for example, what are your most important goals if you were to get sicker? What are your biggest fears and worries about the future with your health? And what abilities are so critical to your life that you can't imagine living without them? So it starts actually with asking patients what their understanding of their illness is, so that you get a sense for where they are in terms of their understanding. Yeah. So it's meant to be titrated to where the patient is, and to really have a gentle, earlier conversation about values and goals.
Yeah, I'd say much of this comes from the standard palliative care canon, and the question. And of course, I trained with Susan Block, so it's very familiar to me. It's like sort of bottling up a lot of what Susan Block's been doing her whole life and teaching to all sorts of people. But the one aspect I think a lot of folks struggle with is this question about trade-offs. And the way you phrased it just there, what sort of abilities, can you say that again?
Yeah, so what abilities are so critical to your life that you can't imagine living without them?
That's a great question. And that's something like, if you take away something from the guide, maybe that's new and gets a new type of language that you could use, a pearl right there. What sort of abilities are so critical to your life that you would have trouble living without them? Something like that.
Absolutely. Yeah.
And if I'm interested in learning more about the guide, can I download it? Is it accessible?
Absolutely, you can download it. You can go to the portal.ariadnelabs.org, which is our community of practice. We have almost 1,700 people, and we have webinars on each step of the program, like training, or how do we get this into my electronic medical record, or how do I measure this, those kinds of things.
And just to emphasize here, it was much more than the guide itself, right? You had like a mailing out to patients beforehand, sort of like, so there was a patient activation component. There was the training clinicians themselves, but there was also a structured EMR form.
Yeah. So the structured EMR was probably the most difficult part of this. So we first built it in our homegrown electronic medical record system and then replicated it in Epic. But the whole idea behind it was to have a single source of truth for what matters most to the patient. What do they care about? Do they want to get to their granddaughter's graduation? And have a place where everyone, including nurses, social workers, chaplains, everyone could document in one place. And it also included, healthcare proxy, code status, those kinds of things as well.
Any other system changes that you guys did?
Yeah, sure. So I think the clinicians in the intervention group identified their patients using the surprise question. Would you be surprised if this patient died in the next year? And any patient for whom the response was no, I would not be surprised, was eligible.
Now remind me.
That was also, I was going to say, that was the one that crossed to the control group as well. So the control, just going back to the intervention for a minute, they received a clinical reminder to have a conversation in their outpatient during a typical outpatient visit, as well as the EHR template. And so the intervention clinicians received this package, the tool, the conversation guide, the training with follow-up coaching that was given telephonically or in person or by email, as well as the systems changes. The control clinicians had usual care. The only intervention component that they also had was using the surprise question to identify their patients who were eligible as well.
And remember, I remember an article from Josh Lakin on the surprise question from your group. I thought the surprise question in that article didn't work.
So in oncology, it actually works quite well. The hazard ratio is about 10. And we actually have a paper coming out in JGIM about the use of the 2-year surprise question in primary care patients, and it actually worked a lot better there.
Oh, so, and the first one was 1 year surprise question?
1 year surprise question, but 1 year surprise question in oncology is not too bad.
Okay.
And the other piece of the surprise question, which I think is shouldn't be missed by this audience, is it's activating. So it generates buy-in for clinicians. So if they say, I wouldn't be surprised if this patient dies in the next year, and Joe or I send them an email and say, you're in our trial, have a conversation, they've already bought into the notion that there's something going on and that they should have a conversation. So that piece is really important, that buy-in piece from the clinician, that they had some part in identifying who needed to have it.
All right, so we have this education, systems improvement component. Did it work?
Great question. So we were able to show that we had more, better, and earlier conversations in the intervention group, and that those patients that had conversations had decreased anxiety and depression, and that decreased anxiety persisted. We did look at goal concordant care, which was our primary outcome, and the holy grail, as you noted, Eric, and we didn't have enough patients to actually determine the outcome for that. So.
And just to add to that, I mean, some of the data points that we saw, in terms of more earlier and better conversations, we saw that with this package of tools, training, and systems change, the patients in the intervention group, 96% of them, before they died, had a documented serious illness conversation, so it was near universal access to a conversation. Conversation started significantly earlier, so 5 months before death in the intervention group compared to about 2.5 months in the control group. And we actually saw different conversations happening. So there was a significant increase in discussions about patients' personal values or life goals. So concrete examples from the documentation: patient wants to be able to maintain his teaching schedule, and that's his primary goal. Or a patient who said, I want to be with my family as much as possible, and that means that if the treatment might not extend my life, I don't want to go back to the hospital and I'd prefer to be home. That's concrete clinical information that can be used to make decisions. And so we saw that in 90% of the patients in the intervention group compared to fewer than half in the control group. And those were some of the differences that we saw in the conversations themselves.
So let's talk a little bit more about measurement. I don't want to get a little too much in the weeds because, as Eric said, I'm a clinician audience.
You gotta watch out for Alex getting wonky here.
Too much in the weeds. But goal concordant care, right? The holy grail, that's what we're about, right? In palliative care, the shortest definition is, matching treatment to patient goals. I think that's how Diane Meyer defines it. So how did you measure goal concordant care?
So we looked for a gold standard, and again, we started collecting data in 2012, and there really wasn't one. And we wanted to have a really patient-centered measure. So we developed our own tool called the Life Priority Scale, and we took it to the Survey Corps at Dana-Farber, and they said, I'm not sure if we're going to be able to do this. But they took it to patients, seriously ill patients, and they could answer. They could answer what was most important. They could rank these things.
So they ranked something like 9.
And they were things like, live as long as possible, not be a burden, be comfortable, those kinds of things that we know are really important to patients with serious illness. And then they could rank it on a Likert scale, and they could also force choice rank.
And then after the patients died, you would go back and ask their loved ones?
Loved ones, and that was actually quite hard. And we didn't have as many patients die as we anticipated, which is a good thing. We had immunotherapy sort of came of age in our trial, which is good. And it also is quite hard to ask bereaved family members these questions while they're quite soon after their loved ones are ill.
Right.
So.
And then you would ask them what? Like how many of these were the goals that they said that they articulated they were important to them near the end of life?
And then we asked the family member what were their important goals and how much did they achieve them?
And how much did they achieve them?
Right.
Okay.
Right.
And goal, how did you, like what was goal concordance? They have to be like 1 out of 1 or 3 out of 3?
So for example, if their goal was to live forever and then they
Right.
didn't live forever.
Right, exactly. It was quite hard to do this actually. So we had we added them up and we added and then we saw what the match was.
Okay.
Yeah.
And you had another co-primary outcome, which was
Peacefulness.
Peacefulness. Could
Yeah.
you talk about what is peacefulness?
So peace is a measure by Holly Pregerson. It's peace, equanimity, acceptance, and the cancer experience. And we measured that actually every 2 months as we did anxiety, depression. And so that also, we looked at that in the last 3 months of life and we didn't see a difference.
Equanimity?
Equanimity.
Can you describe what that is? Like, I remember Alex once wrote for me in one of my letters of rec equanimity, and I had no idea what it was. And I can't imagine family members or anybody what is that? What do you?
Well, I think it's to me what the peace measures or was trying measures is how it's about acceptance. There's 2 subscales. And I think that, do you want to try to answer the equanimity?
Yeah, I mean, I don't know if I can give a specific answer. I think I'll just,
Alex, why did you put it in my letter?
Alex can answer. No, I was just going to say, I think all of us know that patients living with serious illness, especially as they get sicker, experience significant distress. And that distress comes in many forms. It can be emotional distress, often it can be physical distress, confusion, isolation, as well as existential. And I think, there are many measures of this. We used, well-validated, widely used measures like anxiety and depression. And peacefulness is just trying to get at the measure of how patients coping over the course of their illness and their acceptance of their illness. So I'm not sure specifically how the equanimity piece relates to that, but I think it's meant to be another measure of that well-being, if you will, as someone is approaching the end of their life and living with a serious illness.
So we recently did a podcast with Doug White, who published a paper in New England Journal about sort of nurse-led intervention for surrogates of seriously ill patients in the ICU. And his primary outcome was also negative, and that was depression, caregiver depression. And so I think there's if you could do it over, would you change things? Which is, hard to say because there's a reason that we pre-specify endpoints, and we certainly don't want the pharmaceutical industry gaming primary endpoints and changing them around. But to ask the question, if you could do it again, would you choose this? How would you change the way that the trial is designed and structured?
I mean, one of the things that I feel like I've learned, it's been quite some time, is that we could do a better job of measuring earlier and upstream outcomes. So we measured peacefulness in the last 3 months of life and goal concordant care in the last 3 months of life. And I think as a field, thinking about upstream, because it matters how people are living the entire time they have serious illness. And so, and we did measure that, our anxiety and depression over the entire span of the study. And so I think thinking about those kinds of that idea of measuring earlier and upstream outcomes is really important.
And just building on that, I think there's a lot of exciting work happening now, with our colleagues in palliative care national organizations defining these outcomes, the process and outcome measures in serious illness that are really important to patients, are also measurable and actionable, and are sensitive to communication interventions, I think the field has moved forward and is continuing to move forward. I'm personally really excited about measuring conversations themselves, because we all know that it's the right thing to do. And so measuring conversations was a part of our trial. I think that I would repeat that. I'm really excited about the patient experience work and caregiver experience, because I think, as Rachelle said, we all know that communication has the power to transform how patients and families experience care, like not only at the end of life, but over the course of illness. And that body of work is ongoing and really exciting, and something that I'm curious to see it linked to communication interventions as they continue to develop and grow.
So interesting you phrase this as a communication intervention. I wonder if you would say it's an advanced care planning intervention. And there have been a number of, there's this big question out there about, does advanced care planning do anything? And, some will use your data to say, no, it doesn't. Look, it was a negative study. And others will say, look at all these wonderful outcomes, which weren't primary outcomes, but were incredibly important: reduction, anxiety, depression, documentation, goals addressed, et cetera. Is this an advanced care planning intervention?
So I think of advanced care planning as a large bucket. And so, everyone, all of us should have healthcare proxies. Maybe you have an advanced directive, but serious illness conversations is a subset of advanced care planning. And it's for patients with serious illness or life-limiting illness. And it's a different conversation. Honestly, asking that question, what abilities are so critical to your life, or how much are you willing to go through for the possibility of more time, is a question that people with serious illness think a lot about. And for a healthy person, it's a little more abstract. So I think it's a different conversation, but it's a piece of advanced care planning.
All right. We also have some people in our live studio audience. So if you have questions, submit it to Twitter. Or walk up to the microphone, and you can actually ask your question from the microphone. While people walk up, again, encourage you to walk up. I got one other question, is why did it help with anxiety and depression? Like what, I have them talk about their goals. What about that led to less anxiety? I'm having a hard time making that connection.
So I think that we have theories, and I think we're really excited about those findings on anxiety and depression. So there was another paper that just came out from this trial a couple of weeks ago. We audio recorded 30% of the conversations that happened between the oncology clinicians and patients using the guide in the intervention group. And so one theory about why it led to reductions in anxiety and depression is that it's therapeutic to talk about your fears, your hopes, what your worries might be for the future, even if you can't fix them. And so what we found from those data is that patients were really able to go there. When you asked them the open-ended questions that we said, they shared their hopes, their fears. They brought stories about prior experiences that informed how they think about trade-offs, how they think about certain decisions. And I think that that's really powerful and has therapeutic benefit. And the second hypothesis or theory is this idea of preparation. So I think many of us know that these conversations happen so late often that patients kind of crash into these conversations, when they're very sick or in the hospital. And what we're trying to do with this program is move the conversations earlier to gentle, patient-centered conversations about values and goals that allow patients to plan and prepare for the future. So those two ideas, it's therapeutic to talk about what worries us and our hopes, and it also can be helpful to prepare are the potential links. Again, they're theories.
So last question for me before we get to the other, the Twitter questions and people going up there. You mentioned that there were very few people to evaluate for the primary outcomes in particular.
Right.
And not for the outcomes that you abstracted from the electronic medical record or the surveys, you had more folks. But for the primary outcomes, I remember it was something like 30-something people in both in the intervention and 30-something in the control group. Very small numbers. And if I remember your power calculation, you kind of needed 200 to really get a good sense. But still, was there some indication from the effect estimate that this might be effective or potentially harmful?
there really wasn't enough data there to look at. We will be doing a second paper that Justin will write about the actual data from the goal concordant from the life priority scale, and that will be published at a later date. So,
And could you say more about why is it so? I mean, these trials are hard. This is a single site, so these are like your friends in oncology that you're getting to do this. Still, it's hard to recruit enough people to get enough patients who die for these studies.
So we had 72% participation at Dana-Farber, which we were pretty proud of from the clinicians, which is fantastic. And we had a participation rate in patients that was pretty similar to other trials of seriously ill patients. And so, like I said, the death rate was much lower than we expected, which, it's hard to get upset about that. And then the bereavement surveys were much harder than we anticipated. So, and having the match. So I think picking us, I think a simple, is pick a simpler outcome that's more upstream to your intervention.
Great.
Yeah.
All right, open it up. From our live audience.
I'll ask people to come to this point here, and if people want to come to that point, I can bring the mic, but if there's not a long line, come over here.
Hi, my name is Cynthia from New York. I have a question. Actually, I have two questions. One is, since there's quite a bit of anxiety and depression, how many of these patients needed actual mental health interventions? And would that be a confounder? And the second question is, these conversations are tough. How translatable do you think they would be in patients who don't speak English?
Those are two great questions. So the first question, the translation question is great. We have the guide translated into 10 languages that's available on the Community of Practice that you can download for free. That being said, they've been translated and back translated, but we want people to use them, and we're actually asking for feedback. So we had a group in British Columbia actually do that work, and they would love to hear from you. So if you have non-English speakers that you want to try it out with, I just went to Japan and we used the guide there, and I think it does probably require an adaptation process, and there's a professor, Kazawa, that is working on that and putting together a group of people to think about that. Your first question was about mental health. Right. So the Dana-Farber IRB is takes very good care of their patients. So in the GAD 7 and the PHQ-9, there's a question about.
Those are measures of depression and anxiety respectively.
Exactly. And there's a question about if the patient is at risk for harm or self-harm. So we did have a couple episodes of that happen during the trial where we did intervene and offer a psychiatry visit that day, and I think it happened a couple of times.
Mm-hmm. Were there higher rates of antidepressants and anxiolytics in?
We didn't look at that.
So it wasn't examined. So.
Yeah.
No.
Yeah.
I mean, the randomization worked in terms of the factors that we measured between intervention and control. They were similar, no differences, but we didn't look
at baseline.
At baseline.
Right. And I think I'm remembering in Jennifer Temmel's trial, there was reduction in depression, and there were more antidepressants prescribed in the intervention arm.
Yeah.
So how about another question from the audience?
Yes, I was wondering if you gathered any information at all or data at all on situations in which there might have been a discordance between a patient's goals and treatment preferences and their family members, and what the family was hoping or wanting for the patient. I encounter that a lot.
Yeah, I think that is very common. We, in terms of the family members who were also part of the trial, they were actually reporting on their perception of their loved ones' goals and whether they were met. Is that right, Rachelle?
Yes,
as opposed to their own kind of goals for their loved one. That was how we examined it in the trial, but I think that's a really important point because this is a unit. I mean, the patients and families, that we're aiming to improve care for.
And just a follow-up to that, I wondered if that came up then in your follow-up interviews after the patient was deceased.
In our bereavement interviews, I don't recall that.
We haven't. We've analyzed the main outcome for goal concordant care, and there's still data actually on the interviews themselves that we haven't analyzed. But that's something for us to look out for.
Yeah.
Going back to this lowering anxiety for the patients and families, I wonder what your thoughts are about the use of the patient activation component and whether that may have helped in lowering anxiety, giving a sense of control over the conversation.
Yeah.
And I think I might be about to embarrass myself, but Rachelle, didn't you write the commentary for the Randy Curtis article that came out
We
over the
both wrote
summer
it.
about?
Yeah.
Oh,
Yeah.
sorry.
Yeah.
And kind of parallels between that. For those who don't know, that study looked at advanced care planning and using a tool given in advance to patients to essentially allow them to indicate what level of information, like essentially information preferences.
Right.
There's a
before
podcast
they
on
walked
that.
in.
Yes, there is a podcast on that.
There are about to be a few more.
Yeah, that's great. So the question is about anxiety, and just let me clarify a little bit what you're getting at.
I guess I wonder if the fact that they were given a sense of what was to come
Yes, I
helped.
absolutely think that giving, I mean, as Joe said previously, I think all of us has probably experienced this in palliative care, the relief that some patients have when they talk about these things with someone else, even though we as clinicians aren't really fixing anything, but that they feel heard. I think is really important. And I do think there is a sense of control if you can say, you know, this is what's really important to me. I want to be at home. You know, I want to be at home with my daughters and my grandchildren, that they can feel. And the other thing that is, you know, I was just talking with Susan about this, and I think there's a worry of, like, when you're seriously ill, expecting the worst. You know, they imagine something that's actually worse than what is even possible. So the opportunity to do some I think pediatrics does a great job of this, of anticipatory guidance, or letting people know what to expect is really a powerful antidote to anxiety.
Yeah.
So.
Hi, I'm just wondering if there was any piece of your trial that looked at the provider perspective, like from the oncologist, and how they felt in the intervention arm using the serious illness guide versus not.
Yeah, so I think, so we have collected clinician acceptability that will be reported in a separate manuscript. You know, I will say, I'm taking off the researcher hat just for a minute and putting on, you know, many of us do trainings of, you know, clinicians in conversations, and both of us have done coaching. You know, there is an intuitive sense that when clinicians are prepared and feel skilled and confident and supported in the environment to have these conversations, their distress goes down in having the discussions, because clinician distress and having these emotionally complex conversations is real, and worries about harming their patients, concerns about the timing. And so with that support, you know, their distress could go down, and they might experience more satisfaction in their role and more meaning in work. And so again, that's not coming from the trial, that's just our intuitive sense, and something that we've all felt from experience. And I think that thinking about the impact of these conversations on clinicians is going to be a really important kind of area of research.
I also, you know, I thought back a lot about what I felt like when I was starting this, and I felt like I was going to be the nag of Dana-Farber. Like, have you had your serious illness conversation? And, you know, what I found was so incredibly different. You know, oncologists would come up to me and say, I love your study. I know I should have these conversations. I do it. I feel better about the work that I do. And, like, that's really what we wanted to do, was to make it easy. Every oncologist, cardiologist, nephrologist goes to work wanting to do the right thing. It's just that maybe they don't have the right words, there aren't the right systems set up, there aren't the right incentives, you know, to have these conversations. So I think it's really important to remember that we just wanted to make it easy for them, and for them to feel good about the work that they've done. I wish that we had collected burnout on our clinicians.
Right.
We collected that at the end, but not at the beginning.
Right.
So what's the next step here? Like, where do you take this?
Yeah, sure. So we have partnerships with health systems around the country right now who are adapting and implementing this program as quality initiatives for their patients and their clinicians. And these are systems whose leaders have decided that improving serious illness communication at the population level outside of palliative care is a priority, and they're working to align this program with other organizational goals. And we're working closely with Vital Talk and CAPC in this work, and have brought this to 7 health systems as part of a collaborative over the last year, and another 12 to 15 over this next year. And they are really, bringing this program to life in a comprehensive way for their patients. But there's a lot you can do now, even if the system isn't quite ready to take this on as a large program.
And we have, there's a number of people in the community practice that have taken this as their project, that they come and they teach their clinic or their, small community group. I think it has a bit of a grassroots feel, which is nice. Yeah.
So maybe room for one more question. Is there one more question, Paul?
There's a question from social media here, because we answered your question with that last one. Is that right?
I wanted to ask about vital care, especially how do you combine everything, because there's maybe...
I'm sorry?
Questions about Vital Talk.
Yeah,
Like how do you see yourself integrating with Vital Talk and maybe other advanced care planning tools or communication tools out there like Prepare for Your Care?
So we're partnering with Vital Talk to do our faculty development, and that's an ongoing project with Elise Carey and Bob Arnold, Justin Sanders. And we're excited to do that work, and it will continue for the next year.
Yeah.
So is there time for one from social media?
One from social media.
Hey, this is fantastic. I feel bad my colleague Jeanette doesn't have the mic, but I'll take the prerogative here. This is about the RCT data. Did the length of relationship continuity, in parentheses, or satisfaction with the oncologist impact the effectiveness of the intervention?
So we had really high ceiling effects in our measures of therapeutic alliance. So patients love their oncologists at Dana-Farber. They love them, and we had almost no room to grow at all. So the length of the relationship, patients had to have had 4 visits at Dana-Farber before they were eligible for the trial. So we haven't looked at the exact length of time that the patients were at there, but they had that minimum amount.
There was another question on social media that was around, when will we read about this in the New Yorker? and within that was, how will you tell this story in the media? But we also want the extended version of Alex's sing at the end.
I also heard a small organization called NP. You had to decide between a Jerry Pal podcast and NPR, and you chose the Jerry Pal podcast?
Because we wouldn't bear missing this. But Susan Plock is talking on All Things Considered today. About the
just
trial.
To be clear, Jerry Powell podcast, NPR.
Yeah. If you ever had the choice, I think Rachelle made the right choice. Well, with that, I want to thank both of you for joining us. I want to thank all of our audience for joining us.
Audience.
Jeanette and Paul, thank you. But before we end, Alex, do you want to give a little bit more of the song with maybe our audience?
Yeah.
I
have a little thing to add. So the other reason I love this song is my dad was a great mentor, and I know you're a great mentor. And a lot of people came to me at his memorial and said this one thing. They said, your dad was a great scientist, and he also really knew how to have fun. And so many people said that to me. And when I thought about the two of you, I thought the same thing. I thought it's really hard to ask really hard questions, talk about the science, and also have fun. And I think that you've done that with the Jerry Powell podcast, so I just have to commend you on that.
Thank you.
Yeah. Thank you.
I think that's part of the reason we have the song. It's also to interject a little bit of fun.
Yeah.
And that, shift the tone from a usual academic whatever and get outside of ourselves a little bit. And that's why it's okay when I make a mistake, like I'm about to do. So if you could sing along again on the chorus, maybe with a little clapping, we'll see. How sweet it is to be loved by you. Yeah. How sweet it is to be loved by you. Yeah. I close my eyes at night, wondering where I'll be without you in my life. Everything I did was just a bore. Everywhere Everywhere I went, it seemed I've been there before. But you brightened up for me all of my days with a love so sweet in so many ways. I wanna stop and thank you, baby. I just wanna stop and thank you, baby. How sweet it is to be loved by you. Yeah. How sweet it is to be loved by you. One more time. How sweet it is to be loved by you. All right.
We will have links to all of the articles that we talked about today on our GeriPal website. The podcast should be up in a couple hours, so encourage you to check it out, share with others. Again, I want to thank our excellent guests today, our in-live studio audience, our Twitterati for managing the booth,
And for the live filming.
and Ann Kelly, our videographer here in the front, who also designed the picture for our GeriPal PalliMed swamp crawl that's going to happen tonight. Everybody in this room is invited. Sorry for those who are listening on YouTube who are not in Orlando, but at 9 o'clock tonight, we're going to start off at Cuba Libre, and then we will be going on to the wee hours of the morning. Invite all of your colleagues, your fellows, anybody else to join us at the swamp crawl. And with that, we will end this podcast. Thank you, everybody.
Thanks, folks.